start it.
Second,
Yeah,
Rajiv,
after that.
just give me a minute.
Great. So I think we are live streaming now.
Rajiv, just give me a minute. Perfect. I
And
think we are live.
so it's a big honor, and thank you everyone for joining this ISAKOS webinar that is conducted together with the Indian Arthroscopic Society. We're very, very proud to co-host this webinar. And we have amazing speakers that will try to get a little bit of detail in all the big questions that we have in the patellofemoral world. We are very, very happy to, see a lot of people joining. One of the things that would make us help to get to your questions would be to put them in the chat as they evolve. So the speakers can, take on of these. And if you read them down, that would be great. And with that, I think, I can ask my co-moderator to say a few things. And then we can kick off this amazing webinar.
Thank you, Nicholas. And it's a pleasure that we are having a joint webinar of ISAKOS and IAS. And we look forward for more such combined webinar. And we have very good faculty from all over the world. And thanks, ISAKOS, for arranging it. I would like to thank especially our president, Dr. Arumugam sir, and our past president, Dr. Sachin Tapasri, our past secretary, Dr. Sandeep Biraris, for making this possible. So looking forward for a great show.
So over to you, Dr. Petri.
Yeah.
So we'll start with Dr. Petri Silamkas from Finland. Depending on what time of the world you will see the time zone. So Petri is gonna talk to us about some basic things of the patellofemoral joint, and we'll specifically discuss the anatomy and the biomechanics. Petri.
Thank you very much. It's afternoon for me. Good afternoon, everybody, and wherever you are. So it's nice to see many people attending this webinar. Thank you for the Indian Arthroscopic Association and ISAKOS for having me, of course. So we're gonna kick off this webinar topic of anatomy and biomechanics of patellofemoral joint. It's a big chapter of this topic for sure. So I'd like to introduce you to the main anatomical factors of patellofemoral joint, as well as their importance in clinical implications of patellofemoral joint biomechanics. So the patellofemoral joint is a unique and complex structure consisting of static elements, bones and ligaments, and dynamic elements, the extensor mechanism. So basically, we have a ligament restraints against lateral displacement of the patella, for example, MPFL. And then we have also individual bony structure of the patellofemoral joint, as well as the lower limb alignment. And it's very important to understand what comes from which structure or abnormality. So here you can see some anatomical factors related to patella instability. What is the patella height? How is the patella tracking against the trochlea? What is the geometry of the trochlea? Any dysplasia there? What is the axial plane alignment? Any rotational abnormality present, or coronal plane alignment abnormalities, a valgus knee or lateralized tibial tubercle? And in addition, we have these dynamic factors and hyperlaxity syndrome related to medial restraints. So please remember that each patellofemoral joint is a unique structure. We have a lateralizing physiological forces affecting to the patella based on the human lower limb alignment. Basically, the quads, the extensor mechanism is pulling patella laterally, posteriorly against the trochlea, and cranially. And MPFL, most important ligamental restraints that is there against the lateralizing forces. Here you can see how complex the result of these forces are. My own knee, by the way. So the ligament stabilizers, we have MPFL, which contributes about 60% of the force against lateral displacement of the patella. We have medial patellatibial ligament, which is about 20% of the force against lateral displacement of the patella. MPTL works more in deeper flexion angle. And it's very interesting, this medial patellofemoral complex entity. You can see here from the cadaver example how there are fibers all the way from the medial patellofemoral ligament up to the distal quadriceps tendon, and it's really a big wide attachment on the medial patella side. You might call it a complex. I think it's a good way to think about it. So what we can see in imaging studies in a MRI, for example, we can make the diagnosis by detecting the medial patellofemoral ligament injuries, the location, the type of an injury, and then we have a diagnosis of patella dislocation. And also we do need these diagnostic tools for assessment of any kind of patellofemoral abnormalities, the predisposing factors for patella instability. So in addition to have a ligamentous injury, there's certainly different prognosis in these patients. For example, on the left, you can see very well structured trochlea, where the patella sits very nicely on the road. And on the right, you can see very unstable, convex trochlea, very dysplastic, very unstable in its nature. So certainly bone morphology plays a big role in patella stability, as well as the dynamic mechanism who is driving the vehicle. So to sum up a few most important anatomical factors related to patella stability: patella height, the abnormality is patella alta, trochlear geometry if there's any dysplasia, or rotational abnormalities. And a valgus aligned knee, a lateralis tibial tubercle, even though it might have quite a minor role as an individual factor. But we can see from the studies that quite many of the researchers have found that the patella alta is a very important factor for patella instability, as well as trochlear dysplasia. And therefore, might be these three the most important, which is playing the role related to patella dislocation. You might say them as a predisposing factors for patella instability. So how to suspect any of these? You need a careful physical examination, of course. The patella tracking is very important to assess, to see how the patella tracks. For example, on the right side, you can see very abnormal patella tracking. It's a habitual dislocation in extension, and you might suspect of a trochlear dysplasia. On the left side, you also see a patella tray tracking, perhaps from patella alta. So physical examination has a key role. And then you have a suspicion of these bony abnormalities. Patella alta, one of the most common, I would say, can be defined as abnormally high positioned patella. There might not be any overlapping between the patella and trochlear cartilage in near extension, and therefore the patella engages the trochlea only in deeper flexion. You might do the diagnosis from the radiographs. Caton de Champs is my personal preference, most easiest measurement. You might use MRI for more accurate diagnosis of the patella and trochlear cartilage overlap. The patella trochlear index, very useful. You can see how the cartilage overlaps. Sometimes the radiograph indices might be even normal, but there still might be a patella alta case if the trochlea is short in a craniocaudal distance. And therefore, this is a very useful method to assess it. And if you need to address patella alta, of course, you need to distalize the tibial tubercle. That's a very good solution for that. So in addition to patella alta, maybe one of the most common, or even the most common of predisposing factors for patellar instability could be trochlear dysplasia. We do know these very well-known de Jour classification, how you can measure the bump, the double contour sign, and you can classify which kind of a dysplasia it is. Additional, maybe a quite simple tool to diagnose trochlear dysplasia is the lateral trochlear inclination angle. So it's the slope against the lateral displacement of the patella. And whenever it's close to zero, you eventually have a flat trochlea or even convex. And that is also, of course, a clear sign of a severe trochlear dysplasia. We do have this de Jour 2.0, what was it? More modern classification of trochlear dysplasia, that you can measure the inclination angle in addition to the sulcus angle and the bump height, and therefore you have an idea if you need to address it surgically. So sometimes the trochleoplasty is necessary. Most often in this kind of setup, the only surgical option to solve the symptomatic J tracking or habitual dislocation. You can't do it with soft tissue reconstructions only. And there's another presentation in this webinar about trochleoplasty. And I would also highlight the rotational abnormality importance to the patella stability. In a case of increased internal torsion of the femur, as you can see on the left, classic squinting patella, when the patella are facing towards each other, when the foot is faced forward, or on the right side, you can see increased external tibial torsion, unilateral on the right knee. That causes increased lateral vector to the patella, might need to be addressed to correct patella tracking or to stabilize the patella. It's very hard to put any threshold here, but quite often it's clearly abnormal that you can see already on physical examination. But it's very effective surgery. For example, increased internal torsion of the femur. You can do the derotational osteotomy to correct that. As in this case, has been proved to be very effective to correct patella tracking. And we need to understand these biomechanical principles in determining the surgical correction for patella dislocation. We do have a ligament insufficiency, but it's not just the MPFL for all. We need to have these a la carte additional bony procedures available in our toolbox, or you need a friend to do that for you. And of course, it can be very challenging in patients with these varying bony abnormalities. So please consider the medial patellofemoral complex very important for patella stability. And the bony structure is always individual. It's different for a person to another. And remember to assess any low limb alignment in rotational and in a coronal plane. So each patellofemoral is unique. Please use the ligament reconstruction, quite often the MPFL reconstruction, and tailor the bony procedure individually. So thank you very much.
Thank you so much, Petri, for this wonderful introduction and, going through the anatomic features of, the patellofemoral joint. And thanks for staying, on time as well. Let me see if there are any, specific questions from the chat. Nothing specific, but again, please feel free to add these. I'm sure there would be some as we go. And now we have the next speaker that's gonna be discussing if we, yeah, go ahead.
We can have one question, Dr. Petri. So quite often it happens we have planned for a bony procedure with MPFL, but after the bony procedure we see the patella is very stable. So how often you think that you should not do MPFL, just come out with the bony procedure?
I would say I always combine the MPFL with the bony procedure. It's tempting not to do that if you are very good in your bony surgery, but still, close to extension, there's quite a high risk of ligament insufficiency. So it's very well tolerated procedure, the MPFL, if you do it right way, and I think should be combined in every case.
Welcome, Dr. Sundarajan.
Perfect. So let's move to the next speaker, and we need to kind of stay on time, so we'll have more time for discussion. So next we're gonna hear about predicting the risk of recurrent patellar instability.
Okay, greetings from India. Can you hear me?
Yes, very well, sir. Please go
You are
ahead.
audible.
Thank you. And I want to thank ISAKOS and Indian Arthroscopy Society for giving this opportunity. So my topic is about can we predict the risk of recurrent patellar dislocation? I think the risk of the risk protection for the recurrence depends upon the three important factors. One is the demographic parameters, second is the injury mechanism, and third is the anatomical factors. When you come to the demographic factors, I think this is very interesting review paper from the Parek from the US. It gives a lot of information. Sometimes we think that the younger age patients are at higher risk group, but you see this kind of literature here. So only one paper from Belkorak shows there's a 11.2 times higher risk of recurrent patellar dislocation in a younger age group that is less than 16 years. We see the all other articles is almost like 1 to 2%, but it's not a huge, but still it's in a higher risk side. And also you see the skeletal immaturity, again, the Lowell paper has shown that 2.2 times higher than the normal adult patients. And compared to the female gender, we believe that female gender has got a more prediction for the recurrent instability. But if you see that except that Christensen's paper, which shows 1.5 times more risk than the all other group. Still, the rate of recurrence after first-time lateral patellar dislocation was 62.5% if there was a past history of contralateral lateral patellar dislocation. That is an interesting fact to predict the recurrent patellar instability. When it comes to the injury mechanism, again, the sports-related versus non-sports-related, I think all of us are aware that the 5-year recurrence-free interval in sports person is only 53%. But if we see the non-sports persons, it is almost 76%. So we know that any sports person, they are more prone for high risk of recurrent dislocation. When it comes to the anatomical factors, we know these are the very important. There are so many anatomical factors which can result in recurrent patellar dislocation. The most important which we consider is the trochlear dysplasia, patella alta, increased TTDG distance, and patellar tilt, and increased Q angle, and genualcum plays some part. Even though all other parts are involved, they like patellar morphology, MPFL insufficiency, rotational, torsional issues, and retinacular contracture, but they constitutes only small percentage. It is very difficult to predict the high risk. When it comes to the trochlear dysplasia, I think other than the type A, which is the crossing sign positive, which is type A, compared to the type A, type B, when it includes the supratrochlear spur in the radiological, and when it comes to the type C, it includes the double contour sign, crossing sign, and supratrochlear spur, and type D is almost like a flat femoral condyle. They have a high risk of recurrent patellar instability. When it comes to the patella alta, again, there are many ways you can measure it, but whether you are Ketten-Deschamps or the insult solvity, anything the cutoff value goes more than 1.2 to 1.5, then probably you should consider patella alta. Depends upon, you can predict that the patient can have a recurrent instability. That depends upon the method of the calculations. The other important factor is the TTDG distance. We know that, again, the cutoff value is more than 15 to 20, but sometimes when the CT scan shows more than 18 mm, then we may think that this patient can have a high chances of recurrent patellar instability. Again, that patellar tilt angle, again, you see that the normal is less than 15 degree. Anything more than 20 can be an abnormal. Then possibility these patients can have a recurrent instability. At the same time, torsional deformities like excessive anteversion, which I'm not talking about here, the numbers are not huge, but these patients who had a femoral anteversion, excessive anteversion, also have a high chance of recurrent dislocation. And also we know that this very important score, patellar instability severity score, which was published in 2014 by the Balcock et al. It's a very important score, which all of us should understand that anything age less than 16 years, they have high risk of 1 point. Is bilateral instability, again, another 1 point. Trochlear dysplasia, they have a 1 point mild. If it is severe, includes 2 points. Anything with the patellar height more than 1.2, that is then include 1 point. TTDG distance is more than 16 mm itself is then a 1 point has to be included. Then patellar tilt more than 20 degree, then 1 point. So the total score comes around 7, 0 to 7. Anything goes more than 4, then we should predict that this patient has got a high risk for the recurrent patellar dislocation. Then another important classification is the WARFs and state classifications like Stubbs and Ampere for the shoulder instability. I think most of you know that what is WARFs is the weak, atraumatic, anatomically risky, and pain and subluxations. The another one is where happens because the post-traumatic conditions, they have a strong anatomical post-traumatic normal anatomy. There is no risk factors and instability and dislocation. So these patients have a less chance than the WARFs. They have an excellent correlation with even the instability severity score. If you see the high chance of recurrence in WARFs, that is a weak atraumatic cases with risk anatomical factors is 4.4 times, but in the post-traumatic cases, it is around 2.5 times high risk of recurrence. There is another systemic review and meta-analysis which was published in 2020 by AGSM, where we know that these are the factors which are predicted for a high recurrence dislocation, like younger age group, open physis, trochlear dysplasia, elevated TTDG distance, and patella alta. So these are the anatomical factors Then these two are the younger age is the demographical features, which you could predict this. Again, they also concluded that patient gender and history of contralateral dislocations were not found to be a significant factors, which we can keep it in mind. Then another paper which shows the very interesting paper which shows the cartilage degeneration of the first time dislocation, which many of us may not think about it, where here that analyzed 20 patients with a mean age of 28 years, followed up with the MRI for 8 years with the 3 Tesla MRI scan, whereas 14 of the 20 patients after 8 years that showed that medial patellar cartilage lesions on index MRI. On follow-up, it was around 100%. From 70% to 100%, you can see that almost grade 3 to 4 ICRS. So only 5 of 14 patients had instability symptoms, but these patients had a cartilage degeneration as an important finding in this paper. And also they showed that central patella also had showed some significantly involved cartilage damages in the majority of the patient. And some cases, even lateral tibiofemoral involvement also grade of arthritic of 1 and 2. So they can show that it shows that any patellar dislocation can due to development of generalized knee osteoarthritis. Instability symptoms of patellofemoral joint, however, are not related to the severity of the deterioration. So this also we have to keep it in mind when the patient has got a first-time dislocations. If this is Magnuson et al. Has published, anybody who has got a first-time patellar dislocation, 1/3 do well with return to previous level of the sports. The another 1/3 will have a recurrence and require surgical stabilization. 1/3 may not be confident, they may have a pain, apprehension, and failure to return to the previous level of the sports. I think that is our important factors. At the end, if you see the factors for the recurrence, one is the young. Again, female is controversial. Gender is not supported with all the literature, but we can keep it in mind. Bilateral, again, in some literature supports, some literature doesn't support for the recurrent instability. However, anything with the atraumatic disorders with anatomical risk factors like trochlear dysplasia, elevated TT-digit distance, and patella alta, definitely they have a high risk for the recurrent patellar dislocation. To conclude, standard principle of conservative treatment for the first-time dislocation is challenged now with all these literatures. Younger patients have a more recurrence, and patients without recurrence may still have a functional decline or arthritis in the future, as per the previous paper which I quoted. Though one factor may not help in formulating the guideline for embarking on surgery for the first-time dislocators, still the instability severity score still is a good prediction model, which you can keep following that. Maybe we need a further studies to get a robust prediction models. Thank you very much.
Thank you so much for the very insightful presentation. I think it opens up, a lot of discussion and a lot of things that, we are thinking. There is one question that I would like actually to get the thoughts of everybody in the panel. It's about trochleoplasty. So I'll let it be for the time being, because I'm very, very excited to go to Australia now and discuss patellofemoral instability and when and how early can we treat surgically.
Thank you so much. It's a real honour to be able to participate in this webinar with so many esteemed presenters and faculty. My name's Shiana, and I'm going to be addressing the somewhat ethereal nature of patellofemoral instability in the pediatric and adolescent population. And I have to say that it's really lovely to see our ideas and our concepts sort of now consolidating in both the literature and our kind of understanding of the patellofemoral joint, because I'm going to be mirroring a lot of what Petri said in terms of the biomechanics and really using an a la carte approach to these patients, because they don't all fit the box. These are my disclosures. So in the pediatric and adolescent population, we are presented with a very variable cohort of patients, which the literature can't necessarily help us understand. So this is a little syndromic child who has a very unusual torsional profile with externally rotated femurs, internally rotated tibias, fairly obvious. It looks like valgus, but I think it's a result of the torsion. and she has chronically dislocated bilateral patellae. Sorry about that. This next patient is an infant with Blount's disease, which has nothing to do with the patellofemoral joint routinely, but they've been treated with guided growth and then gotten lost to follow-up. And so the only issue here is gross valgus. It's the only deformity in the coronal plane. And as a result of the valgus, you can see on that right-hand image, the patella has started to sublux and subsequently dislocated. So this little child at the age of 4 had a chronically dislocated left patella, sorry. And this little lad is an unfortunate child who had meningococcal sepsis as an infant and lost all 4 limbs. Now, he's got a very unusual shaped patellofemoral joint due to fascial arrest of the femur, and he started developing varus in the tibial stump, which we then had to correct with an HTO. Sorry, I don't know why it keeps jumping. And after the correction, he started dislocating his patella, so it's a kind of iatrogenic issue. But you can see on that third slide the relative alter that he has due to the fascial arrest and a very short trochlea, which we then had to use a distalization procedure for to fix. So like Petri said, patellar instability presents in a variety of different ways in these patients, and it carries its individual set of challenges. And I like to say to my patients that every knee on the outside is as different as our faces are. Sorry, every knee on the inside is as different as our faces are on the outside. And the biomechanics of our kneecaps depend primarily on our underlying anatomy, which is very variable in children. And we need to be aware not only of all the anatomic variability that predisposes patients to instability, but the additional comorbid conditions that we see in many kids, such as Down syndrome, the hypermobility spectrum, ASD and toe walking, and then also the anxiety of the parents, which needs to be managed in order to give your patients the best possible recovery. So in order to do this, we need to assess the patients firstly with our history, and we need to look at the timing of the first dislocation. I also obviously do a birth and developmental history as well as family history, but the timing of the first dislocation, as was said before, as well as the energy of the injury and the number of dislocations that the patient subsequently has, gives me an idea about the severity of the pathoanatomy that we're dealing with. And we have patients that dislocate their patellas when rolling over in their sleep. So that doesn't happen unless there's fairly something dramatic going on. In terms of clinical examination, I like to look at 3 factors in my head. I think of the extrinsic alignment of the limb in the coronal and the axial plane. I think of the intrinsic bone geometry of the patellofemoral joint, which includes the TT to TG distance and the presence of dysplasia. And then I look at the soft tissue balance and whether the patient has through knee laxity. And that can be quite extreme in some patients. We then like to look at all these factors and try and quantify the extent of the pathoanatomy using our radiological investigations. The problem is that we really do need to understand and interpret these carefully in the context, particularly of soft tissue laxity and dysplasia. So for the extrinsic alignment, I'll either get long leg films or an EOS scan to look at the tibial and femoral valgus, and potentially the tibial slope in the presence of alter on the lateral side. X-ray, and then axial slice imaging if I'm concerned about torsion, so we can assess them either with CT or MRI scans. But in patients with a lot of through knee laxity, it's really important to make sure that the limb is not externally rotated in the scanner, because I've had patients have variable TT to Gs from 10 millimeters to 30 millimeters difference, and that's in the same patient as a consequence of the amount of external rotation through the knee. So do be very careful about how you assess that. In terms of the intrinsic morphology, the lateral X-ray gives me a nice idea about what that looks like. And the MRI of the knee, as Petri said, I like to look at cartilage sulcus angle to assess dysplasia. And it gives me an idea about the shape and the geometry of the patellofemoral joint and how the quadriceps force vector will interact across that, which gives us I guess the J sign is an expression of that interaction. The soft tissue balance is only something that can be interpreted through your clinical examination. So it's really important to do that and to understand how that affects the potential laxity through the knee, as well as the MPFL and its likelihood of stretching out once you perform a reconstruction, particularly if you're using autograft. And then in terms of the pediatric population, we address what we can without burning bridges. So in terms of extrinsic alignment, we can address that using guided growth or derotational osteotomies. We can still address the TT to TG distance using a Rugolf plate or Grammont procedure. And then with regards to soft tissue balance, in the congenital cases where they have very tight lateral structures, we can use lateral releases or vastus lateralis transpositions. And likewise, in most cases, I will be using an MPFL reconstruction unless they're very young, in which case I'll tend to still immediately placate with the understanding that I can always come back and do the MPFL down the track. And the PLC reconstructions we reserve for those patients with excessive through-knee laxity. So just a couple of cases to run through to show you examples of this. This first lass is an 8-year-old girl with a 12-month history of left-sided PFJ dislocation. It was a low-energy injury and spontaneously reduced, and she's had 4 further episodes of instability or low energy. And interestingly, her mum's a dislocator and her sister has CMT, and she also has CMT, which was diagnosed after we met. So this is her coronal X-rays, her long leg films, which demonstrate that she does have bilateral lower limb valgus. She has a high Q angle as well as alta. And on examination, she's dislocatable laterally. So she's only 8, and I'm going to primarily address the coronal plane first. So I want to fix the valgus because everything else will depend upon that. The other factors that I'm looking for, though, are obviously the cartilage sulcus angle as well as torsion. And for her, those numbers are on the worst end of normal, but they're not horrendous. So this is my little box, which I use to address all of the factors that I feel will influence the biomechanics of the patellofemoral joint. And I'm looking particularly at the femoral valgus for her, which is 84. She's got a little bit of tibial valgus, no femoral or quads torsion, and she's got a high TT to TG. I don't want to go reconstructing an MPFL on the background of underlying valgus because I'm worried that my tension is going to be incorrect. So I'm going to correct the coronal plane first. And when I started doing this, it was really interesting that many of the kids ended up not having recurrent instability once their valgus had been corrected for at least a couple of years. And then unfortunately, as the valgus recurred, they did develop further instability, which we then had to readdress. But the coronal plane is a really important factor. And I think correcting valgus in this way is a very low morbidity procedure that we should all consider if we're able to. The next case is a bit more complex. She's a 17-year-old girl with mild developmental delay and low tone. She's a W sitter, which makes me think I need to assess her torsion more accurately. And she struggles with sport. But further to the last speaker's point, I think a lot of these patients don't play sport because their patellas are unstable. So it's a very difficult thing to assess in terms of, or to use as a diagnostic criterion for recurrent instability. She does not have valgus, but she does have increased femoral torsion with internal rotation at the hip being close to 80 degrees there and very little external rotation. She's got a very dramatic J sign, worse on the right than on the left, and as it jumps over the lateral facet of the trochlea there. And then we look at her extrinsic alignment. So she's not got too much femoral valgus. She does have a lot of femoral torsion with a femoral anteversion of 44 degrees, and her quads are also externally rotated on the background of that internally rotated trochlea. So that gives me an idea about how far I may need to derotate her femur to match the quadricep mechanism. Intrinsically, she's not great. She's got a high TT to Roman arch distance because of the bump. It's very hard to assess the groove. She's dysplastic with a cartilage sulcus angle of 170, and she has alta. But at this stage, I'm really not able to alter too many of those things. I can change the femoral torsion, and we can do that with a derotational osteotomy, as Petra mentioned before. In the younger kids, I like to perform this proximally. I think it's an easier and more accurate operation. And then we can address the TT to TG distance with a Grammont patellar tendon transfer, and we can also address the MPFL. So this is just a very quick slide showing you elevation of the patellar tendon off the tubercle apophysis. and fixation with the suture ankle more medially. I think I'm actually out of time, so I'll stop there. But thank you for your attention and hope to see you all in Munich.
So, thank you very much, Dr. Shiana. So we do have few questions. So I think we'll take all those at the end only. So we can move on to the next talk about surgical management options for patellar instability by Dr. Juan Pablo Martinez from Colombia. Over to you, sir.
Thank you. Thank you for having me here, and thank you for this invitation. I'm very happy. So we're gonna discuss a little bit about some of the surgical management options for patellar instability. And of course, the MPFL reconstruction, and sometimes you can add the MPTL reconstruction, is the main surgery to treat these patients. In some cases, you can add a trochleoplasty when you have high-grade trochlear dysplasia. But these two topics are going to be treated in the next two talks. So I'm going to center in other stuff like the tibial tuberosity osteotomies, where you can medialize or distalize, the lateral retinaculum lengthening, the rotation osteotomies, and valgus correction. So we're going to treat these topics, and we're going to talk about a little bit about cartilage lesions that, as one of the previous talks said, it's frequent for these patients. So when do we need tibial tuberosity osteotomies? We can do medialization, we can do anterior medialization, we can do distalization. And when, so you would like to medialize when you have an increased TTTG, and this would be like in the CT scan more than 20 millimeters, in the MRI about 14 millimeters, and you have other measurements like the patellar tendon lateral trochlear ridge. And in case of patella alta, you can use the Caton Deschamps, and then you can discuss the threshold, but it's going to be about 1.3, 1.4. Usually I use 1.35. But both patella alta and TTTG have shown in this meta-analysis that are important risk factors for recurrency after a first episode of patellar dislocation. But patella alta is probably more frequent than increased TTTG. For example, in this study, they found that it was a similar value for patients who redislocate versus those who didn't. Meanwhile, the Insel-Salvati index was significantly different for those who redislocate compared with the control group. So probably you will get more distalizations when you do tibial tuberosity osteotomies, but it's probably at the beginning similar. You take the tibial tuberosity with a saw. You can now medialize or you can distalize as you want, depending on how much you need. I like to have big, like 5 or 6 centimeters long, and then you take what you have planned. You distalize and you fix, and you see how tracking is working. But you can also medialize a little bit if you want at the same time. So how do you plan how much to do? So you have your Caton Deschamps measurement, in this case 1.42. You decide that you want to go for 12 millimeters of distalization, and that would change your numerator of this division from 47 to 35, and that would give you a Caton Deschamps that it's around the normal value, 1.06. So I like those 12 millimeters, and I go to the surgery and I take those 12 millimeters, and that's the result that I will get. So you can know how much you're gonna get at the end if you plan. Then you get the lateral retinaculum tightness that you can manage with a release or with a lengthening. I like the lengthening. When you have this tightness and you add medial ligamentous deficiency with patellar dislocation, you have an imbalance of the medial and lateral forces. So you can get patellar tilt, the patella is not centered. And this can also predispose to lateral patellar dislocation and some hyperpression of the lateral facet. This is not intended to be an isolated treatment, but something that you can add to the MPFL reconstruction. So I usually do it, I open the lateral retinaculum in a superficial and a deep layer, and then I can lengthen whatever I feel that it's gonna give me the patella well centered and without tightness in the lateral retinaculum. Some of the thresholds to decide, it's more than 20 degrees of patellar tilt in the images, less of 1/4 of medial displacement in the medical examination, and medial patellar tilt test less than 0 degrees. About the valgus deformity that Sheena showed us recently, it is considered a contributing factor for lateral patellar instability due to the vector applied on the patella, causing an increased Q angle. So when you have open physis, you can use guided growth, as Sheena showed us. And then when you have closed physis, you can use osteotomies, more frequently in the femur, but you always have to measure angles and see where's the problem, because sometimes you have problems in both bones or more in the tibia, but most of the time it will be the femur. About the threshold, it's difficult to have thresholds in the different procedures that we do, but in this recent systematic review, the authors suggest that maybe 7 degrees of mechanical valgus malalignment or having a mechanical lateral distal femoral angle less than 83 could be a threshold, or that's the one they recommend. And they found from this systematic review that in only 9 studies, only 147 knees of literature published about this topic, but results were good with recurrent dislocation of 4% and with prompts that were good to excellent. Then we have to watch out for the torsional malalignment, and we have to do always the clinical evaluation. And then I try to use my clinical evaluation to decide who might need a CT scan to make the proper measurements. The thresholds, again, there are no clear thresholds, but maybe femoral anteversion that it's more than 30 degrees, you should consider. External tibial torsion that it's more than 35 degrees, you should also consider it. And then you have to check for the range and the normal value depending on the method that you're using to measure the femoral anteversion, because it can have different ways of doing it and different values. And also you have to measure your tibial torsion to decide if you need something here. So I have this clinical case of a 14-year-old female with recurrent patellar dislocation, especially in the right side, with torsional malalignment, as you can see in these pictures. She had J sign because of this, and she had positive apprehension and multiple episodes. The torsional measurements showed us that the femoral anteversion was a little bit high, but it was considered for us not to do a surgery there. But she had a lot of tibial external torsion, 44 degrees, and she had also a TTG that was elevated in 26. So we decided to do a supratuberositary tibial derotation osteotomy in this case that could help us to manage the tibial torsion and also to decrease the TTG at the same time. This was her physical exam at the beginning, and at the end we can have no more J sign, and we add MPFL reconstruction also to this surgery. This is the patient 3 months later with her J sign in the other knee, and this one is tracking better. This is another case. This is a 17-year-old autistic girl. It was bilateral patellar dislocation, very hard to, we couldn't touch her knees because of her apprehension, and we didn't have like a patella alta or trochlear dysplasia in this case, but we have a lot of problems in the torsional evaluation with femoral anteversion in 40 degrees and tibial external torsion in 48 degrees. In this case, we decided to do a mid-shaft correction with intramedullary nails, and we didn't do something in the knee. That's very rare. I always do an MPFL, but in this case, she was so much apprehension that we thought that we could have problems in the postoperative period, and it's going very well 4 months after surgery. And last, we're going to talk about a little bit of cartilage lesions, because you can find this in your patients. And this is a clinical case to help us show this. a 12 years old male with first patellar dislocation. The x-rays didn't show much or a fragment, but this patient had a blocked knee. So we made an MRI and we found that there was a fragment that we were looking where this fragment comes from. And then we noticed that it was from the wave bearing of the lateral condyle. So we went to surgery and we found this big problem in the lateral condyle, and we fixed it with screws. Sometimes you can use also sutures, but in this case you had bone. I like to use screws, and we also did the MPFL reconstruction. Then this was last week. We did the 6 months after we took the screws from the knee, and it was pretty good looking, very nice, without like any scars even in the cartilage. So as a conclusion, patella alta is one of the main risk factors for recurrence after a first episode and for failure after an isolated MPFL reconstruction. So you should consider distalization and also medialization in some cases. Torsional alterations should be always evaluated clinically, and sometimes you would need the CT scan to measure and consider corrections. For cartilage, you should be ready in case you need to fix or treat those lesions. Lateral lengthening for tight lateral retinaculum. Genu valgum, you can treat it with guided growth or with osteotomy. And we're going to be talking now about MPFL and trochleoplasties. Thank you.
Thank you very much. I think Dr. Saitna is not there due to some emergency. Dr. Nick, you are going to cover it for him?
I will try. I put some slides together just because I think it's a nice
Important.
topic. Thank you, Juan Pablo, for your talk and for laying the floor for me, and everybody did an amazing job, and I think there would be some overlap. So I'll try my best to fill Dr. Retzner's shoes. He had an emergency, so he wasn't here, but I thought it's an interesting topic to bring up. Apologize for like some of the slides, but and some of them won't make sense. But I'll try my best to kind of share my ideas on what we are looking. These are my disclosures. Nothing relevant, obviously, to that presentation. Now, what is the important thing, and what is what we are looking for? Like, we are going to talk about the single bundle versus the double bundle of the MPFL. And I think what changed our thought process was the fact that MPFL starting being a very effective procedure. For many years, we didn't have a very good procedure to treat these patellofemoral patients. And as we evolve and as we start thinking of what is happening, the idea was that we started restoring the anatomy in a very good, nice manner. And thanks to, very thoughtful leaders in the field, we started examining and, like having with the support of, the Patellofemoral Foundation, with a, International Patellofemoral Study Group, we started looking into these problems. So our way of thinking the MPFL as a single ligament have changed. And, what I'm showing here is that we refer to it as a patellofemoral complex, as you heard before. And when you see the constraints, for lateral patellar dislocation, the MPFL plays the main role in extension. But then in the mechanism of injury of the patellofemoral injury, that's where it happens. So it's a very, very important structure. And then as we talk about the complex, it's very, very important to realize that this, as like the presenter said, it's different in every patient. So as we are trying to replicate anatomy, I think it's very, very important to realize that there are things that they can be different in different patients. So we have all these factors that we know that they affect the Q angle, the height of the patella, but it might be that they have variants of this ligament and this structure that it might be kind of contributing to the effect of the patellofemoral instability in this individual. And then if we are kind of trying to incorporate that, that might be very, very helpful of the success of how we reconstruct that. So if you see the newer studies that point, like if you take the ligament and, not a ligament, a single line, it's a span of fibers that extend from the center of the patella, and it's not alone. They have all of the minuscule femoral ligaments that, ligaments from the tibia that play a major role. So when we try to reconstruct this ligament, we need to be going back to a little bit of geometry lessons and see the vectors. And that is where, the different techniques and the different thoughts started with the MQTFL idea from Fulkerson and, like Miho, Tanaka, who essentially tried to avoid tunnels, connected this graph from the patellar side on the quad and looped it again and fixed it again on the quad. This idea obviously is following the trend of anatomically fixing the axis of the patella, but also avoiding bony tunnels that, like in the old school techniques would have risk for fractures and all these things. Now, as these techniques evolve, questions arise about isometry, about strength. And then the idea was like, okay, how about doing a single bundle? Because the graft was there, a lot of us using allograft. So we have the length of the graft to try to do a double bundle. And this here is the classic single bundle technique, that would have one femoral attachment point and one patella point. But that kind of is very hard to find the ideal point of, of your ligament. And with the idea with the double bundle technique is that essentially replicates a little bit better the anatomy. Now, the more surgery you do, the more risk you're adding. And sometimes, trying to figure out the anatomy, you need to be very, very careful. And when you are introducing two tunnels on the patella, then you have additional risk. So a lot of people moved from this classic double bundle technique to this that essentially use one limb on the patella and then use one limb on the MQTFL technique. And that's, the technique that I do, mainly because, there is a pediatric population that you don't want to add too much, work on the patella, especially if you're thinking that, hey, this might fail. The good thing is that when we see and compare, and this is a recent study comparing single and double bundle technique, and you see here the recurrent instability, it seems that the double bundle offers a little bit more safety on the instability. The Kujala scores and the Lissom scores, as well as the AKDC, I couldn't, find all the force plots here, are kind of borderline, but there is a trend. But what we know and what we see is that both techniques, both the single bundle and the double bundle, is something that effectively can use for our patients to treat patellofemoral instability. If you are thinking whether I'm biased in this presentation, obviously MPFL and QTFL reconstruction, the combined double bundle, is biased, so I'm kind of biased towards the double bundle. But I use sometimes, the quadricep shift technique to essentially take a strip of the quad and bring it down to the patella, which is also a technique that I use, for some of the very young patients. And essentially, this is a single bundle technique. Have I seen, a series? Stay tuned because we are working on this publication. Thank you so much for all the people who work, all of my team, and all the different groups that, affiliate and help us in this research. And hope to see you all in 2 weeks in Munich.
Thank you, Nicholas. You have been last minute savior for us on this topic and well prepared. Yeah. So our next speaker is Dr. Lee Pace from United States. He will be talking on trochleoplasty and J-sign.
Yeah, thank you. Let me, I'm trying to share my screen right now, and I'm gonna have to close all my other PowerPoints here because the thing isn't giving me quite the options that I want. Hang on a sec, let me do this again. And okay, that should be it right there. Okay, let me try that. Here we go. Okay.
Perfect.
All
You
right, you
can
guys
see
all
it.
see that?
Yes.
Okay.
Yes,
All right.
yes,
Okay,
perfect.
thank you. All right, I want to thank ISAKOS for having me talk about this topic, and hello to all of my friends that I haven't seen in a while, and hello to the people that I have not met yet who are on this panel. So let's hop into this. So, when it comes to thinking about patellar instability, I like to think of it as being the symptom of a problem. Like a cough is the symptom of an upper respiratory viral infection. Patellar instability is due to some anatomic risk factor, and we've kind of talked about all these already. But when it comes to trochlear dysplasia, as Petri said, I mean, it's almost hand in hand. Like you almost have to have this in everybody to have patellar instability. There's a few outliers that have something else in isolation, but most people have this. And this has been highlighted multiple times in the literature. This is probably the seminal article that showed that in a population of patients who had failed conservative management, had recurrent patellar instability, and that were indicated for surgical stabilization, 90-ish% of them had some degree of trochlear dysplasia present on their x-rays. And then between 2010 and 2020, a lot of people were looking into all the risk factors for recurrent instability. And no matter how you cut it, no matter how you did the stats, dysplasia was the sole risk factor or the most important risk factor in every study that looked at this. So, I mean, it really is. It is almost a hand-in-hand relationship. The other thing to keep in mind is that there is the natural history of untreated trochlear dysplasia is early arthritis, early chondral defects, and that's been shown multiple times in the literature. So, understanding this as a problem that should be fixed in some people, I think, is very important, not just for the short-term instability, but for the long-term risk of osteoarthritis. So, this study highlights that very well. This is basically a natural history study on accident by the Mayo Clinic, and it showed that about 50% of people who had a recurrent patellar instability had symptomatic patellofemoral osteoarthritis by 25 years out from their index dislocation. Okay, so and I'm going to throw a little controversy in here because I'm good at that. People talk about the lateral tibial tubercle, the TTTG. I don't think that is real. In most people, I think there's maybe a few syndromic patients out there that's real, but there is now a body of literature here saying that a lateral, like an elevated TTTG distance, is probably a radiographic artifact of trochlear dysplasia, and that it's not a real thing. And so a TTO should probably be at least as a medializing TTO should be viewed as a compensatory procedure. So I don't know what real role it plays in treating instability. So the American experience for surgical management of patellar instability looks like this, where you've got MPFL reconstruction up at the top. Everybody gets it. And I don't disagree with that practically speaking, but to Petri's point, you have to understand why you're doing it. And then the next thing is this tibial tubercle osteotomy, and that basically accounts for most everything that people in this country do. And then when you've got the more rare conditions, anteversion, valgus, that sort of stuff, then people understand, okay, I need to treat that problem, right? But trochleoplasty has been looked at as this sort of like, rare salvage procedure that you only do on people you don't like, right? And so I have a much more of a European experience with this. I like to thank, Philip Schottel and these guys that taught me how to do this. And, the thought is here is that you're just treating the symptoms when you take this approach, right? You're not treating the problem. So this is what my algorithm looks like. So people still get this soft tissue retentioning. But if we're going to look at problem-focused treatment, if dysplasia is the most common problem that's out there, well, then trochleoplasty should probably be the most common problem-fixing procedure performed. I'm not saying everybody needs it, but if it's bad enough, that should be fixed. So, and then, the list goes down as the other problems that can be dealt with. So let's walk through this. One of the other things that was on the thing was the J sign. So we'll quickly address that. But I'm just going to walk through what my exam looks like, imaging, evaluation, and surgical indications and algorithms, and then I'll get into the procedure. So here's this J sign. We talk about a jumping J sign. I think that there's a lot of research that's gone into the J sign, which is fine. But the J sign is just a symptom of the patella hitting that convex trochlea and being subluxated laterally. And it's probably influenced a little bit by patellar height and a few things like that. But I think that in most people, if you've got a big convex trochlea, that patella hits it and just goes off to the side. Simple as that. But so the more impressive the J sign is, likely the more severe the dysplasia is. When we do our lateral translation and apprehension sign, you don't just want to check them in full extension. This patient's under anesthesia to make it more dramatic, but in the awake patient, you flex their knee and you check their apprehension through a range of motion. And usually people with high-grade dysplasia, they don't even stabilize until beyond 60 degrees of knee flexion. So that's a nice way to kind of, from a physical exam standpoint, say this person may have a flat or convex trochlea. Imaging, I routinely get 4-view x-rays of the knee. You can do the du jour classification off of this, but I think that that's going to be in support of your advanced imaging findings. You can get coronal plane alignment with an AP hip to ankle if you've got a young person, a bone age x-ray if you think you need it. Here's an example of some valgus in a skeletally immature patient. The MRI is really where you're going to do your is your workhorse, at least for me, for surgical indication. I like to use, and Petri mentioned this as well, that the lateral trochlear inclination angle, that's a measurement of the shape of the proximal trochlea. The thing to keep in mind is dysplasia is a condition of the proximal trochlea. So if you're scanning distally, you're taking axial cuts and scanning through the patellofemoral joint, and you're waiting to see a sulcus, you're past the apex of the dysplasia. So you might be missing really bad dysplasia despite seeing a reasonable sulcus. And so this is designed to evaluate dysplasia where it's at its worst. And I think that's very helpful. Patellar height, I assess on the sagittals. I like to use the patellar trochlear index. I think it's a more useful measurement than the CD ratio, although we don't have pathologic values established for that. So it's kind of a gut feeling. Evaluation of cartilage is also helpful on the MRIs, and then CT scans I reserve for rotational profile analysis. Here is my algorithm for surgery, and I think that I try to keep this as simple as possible, and I think that we can make patellar instability surgery relatively simple. What's the problem? How bad is it? That's the debate. If it's mild, compensate for that problem with an MPFL reconstruction and lateral lengthening. If the problem is severe, fix it, and then you got to retension the soft tissues because they're not going to retention themselves. Okay, so my indications for a trochleoplasty can be put pretty simple. It's a flat or convex trochlea. The lateral trochlear inclination angle, a flat trochlea is going to have an LTI of 0. A convex trochlea is going to have a negative number. A more normal LTI in a controlled population is close to 20 degrees. Okay. There's a couple sort of the big techniques nowadays are all groove deepening techniques, which I agree with. You have the thick flap school, which is mostly influenced by French surgeons like David de Jour. And then there's the thin flap school. Heinz Bereiter is the genesis behind that. And that's what I do is I do a thin flap procedure. So I always do the MPFL reconstruction, but the rationale when done in isolation is that you're compensating for the pathology, okay? A weak MPFL is not the problem. That's a symptom of the problem. So done in isolation, you're compensating for milder pathoanatomy, whatever it may be. When you're doing it in conjunction with a problem-fixing procedure, you are adding it as an insurance policy. If your trochleoplasty isn't deep enough, if your derotation isn't quite enough, you're adding that little bit of extra tissue there to make up for maybe any potential imperfections in your problem-fixing surgery. Okay. And the lateral retinaculum, again, I like to lengthen that with all my procedures, all my patellar stability procedures as well. Here's some video. So here's a pre-op EUA of someone with high-grade dysplasia. You can see again that she can, this patient will dislocate into higher degrees of knee flexion, and she's at, takes her to almost 80 degrees to stabilize. We have about an 8 to 10 centimeter laterally based incision. Petri is slicker than me, and he does this mini open trochleoplasty. I still do this open quad split. I guess I just don't trust myself enough to really reshape the trochlea the way that I want it without it. But this single incision allows me to get to the medial side of the patella to do half of the MPFL reconstruction. And then we do a Z lengthening here of the retinaculum and so you can see here I'm identifying that those transverse fibers that emanate from the iliotibial band, and I'm taking part of them as a superficial layer, and then I'm leaving the deep layer, and then right at the sort of the anterior aspect of the iliotibial band, I do this sort of hockey stick incision. And then beneath that, I can then cut the capsule and I can get into the joint. And then here you can see the quadriceps split here. And that allows me to get a full medial dislocation of the patella to fully expose all aspects of the trochlea, a couple K-wires, and then a Hohmann retractor to get full exposure. As you can see, this is a rather dysplastic trochlea. I'm marking out the pathological medialization of the groove proximally, and then I'm marking out where I want to put the new trochlear groove in line with the intercondylar notch, and then I peel some synovium off so that I can see that non-chondral portion of the supratrochlear spur sweeping up to the proximal trochlea. The initial elevation and for the thin flap technique is done with osteotomes. I use a combination of 1/4 inch and a 1/2 inch osteotomes to start this elevation. And you can see it's just a few millimeters thick where we start. I think the tendency early on is to make this really thick, and that's safe, sure, but it takes forever to thin it out afterwards. So you've got to get comfortable with that sweet spot. I take this all the way around. And then I'm advancing this osteotome, and you can see I'm starting to get some elevation on this flap here. And then there's this proprietary sort of offset marking guide and burr that you can use to sort of further detach at least the lateral side. It doesn't really work well on the medial side based on this approach, but you can use that to further detach the lateral aspect of the flap, and then also do some initial undersurface thinning of the osteochondral flap. Once we get that initial flap detachment, I'll actually get in a chair and basically put myself at eye level with the undersurface of the osteochondral flap, and then I start advancing that osteotome more distally. And I've always got an assistant with his or her finger on the articular surface, giving me tactile feedback if I'm getting too thin. The thin flap technique is great for remolding, but the risk is you can plunge that osteotome right through the articular surface. And I mean, that's happened to me before, as I'm sure it's happened to anybody. But you obviously want to try to minimize that. So, having that assistant to give you that real-time feedback all through the case is very helpful. And you can see once we've elevated that distally, that flap, it can pop up quite nicely. Once the flap is up, I'll thin it out on the undersurface. I currently use this arthroscopic hip burr that I can hold near the burr so I have maximum control on it. And you can see me thinning out. You can actually see the little bone particles kind of flying off. But you got to just keep thinning this thing out, and the assistant's providing some back tension for you and kind of help holding the flap up. And you want to thin this thing out until it's moldable. And so you're checking it multiple times throughout the course of the case to assess moldability of it. And if it's not moldable, you haven't taken enough bone yet. And that's different for every person. A female, you can leave a little bit more bone on it. It's moldable. Sometimes those athletic males, you've got to take a little bit more bone. It can be really razor thin at that point. Once you've got the flap elevated, now it comes the removal of the pathologic subchondral bone to create the new trochlea. So I take this 1/4 inch osteotome from proximal to distal right at where I want the apex of the new trochlea to be, and then I start removing wedges of bone. And I make sure I get the entirety of that supratrochlear spur gone, so everything's going to be flush with the anterior distal femur. And then I'm removing these progressively smaller wedges of bone as I go distally. I want to make sure I have a nice contour, and obviously the more distal you go in the trochlea, the more normal it is. So you're not taking a bunch of bone distally, you're trying to take the pathology and merge it with the normal as you go down. But you save these little bone grafts that I took out for later. So now you can see I have what I think is an appropriate trochlear groove. I think I'm happy with what I've done. So now it's thumb pressure to start molding this into place. Again, if it doesn't mold, then you've got to take more bone off the backside. But you can see here that I'm getting a new trochlear groove. You can see a significant improvement over where I was or where the patient started. Anyway, I like this, but I know when I put my anchors down, it's going to sink it down a little bit more. So I'm going to add a little bone graft here in the next slide. Oh, maybe that's in another slide. But anyway, we're going to add some bone graft to kind of shim it back up. But here's the fixation for this. This is a knotless anchor with a bunch of strands of vicryl suture on it. You only violate the cartilage in one spot, right in the distal central trochlea. The anchor goes there. And then from there, you've now got what are effectively 12 free strands of suture. And we don't have Vicryl tape in the States, so I will put 4 strands together and make my own little makeshift tape out of it. And I actually like that better. It's not as noisy for the patients afterwards. So you can see that's where I'm at with the initial fixation. And I want to add just a little bit more height to this thing. So I've started taking some shims, some bone graft shims, and just sticking them in laterally to kind of, elevate that height up a little bit. And then the one thing I'm doing now that I wasn't, you can see that's a nice, probably 20-degree LTI that I've got there now. One thing I'm doing now that I haven't done in the past is I'm taking some fibrin glue and I'm just sealing the edges all the way around to try to make it watertight. Now you can see, now I'm just going to finish off the other strands of suture fixation. So placing an anchor laterally to kind of hold down that lateral side, and then we'll do the same thing medially right there to complete the fixation. And that is bomber fixation. I mean, those sutures really hold. In fact, you have to be careful not to over tension the sutures because that can actually necrose your cartilage. But you can see that looks, if I do say so myself, that looks pretty beautiful. And without the MPFL reconstruction, you see how stable she already is. And then we close the retinaculum, we flex the knee 70 degrees and just kind of put the 2 layers back wherever they lie, like that. And you usually are getting at least 1.5 centimeters of length. This girl probably got close to 2.5 centimeters of length. So, and then post-op management, this is day surgery for me. They weight bear and they range as tolerated right away. Crutches are for comfort. I don't put them in a hinge knee brace. There is a bevy of studies out there showing consistent good outcomes with regards to stability, patient satisfaction, and activity, and long-term cartilage preservation. So obviously I don't have time to get into all of them, but in conclusion, dysplasia is the principal risk factor in recurrent patellar instability. Trochleoplasty has reliable outcomes, excellent patient satisfaction, excellent stability. I think it should be a primary procedure in properly indicated patients. We can always optimize techniques. And the big thing I didn't really get into is what to do with the pre-existing chondral defects, because most people have some degree of cartilage damage to begin with. Thank you. I hope I didn't go over time, or at least too much.
No, thank you. Really, it was wonderful, and thank everyone for the amazing and excellent quality of presentation. And thank you for staying for the questions. Since we have some, let's start hitting them, and feel free, whoever feels that has something to add, to jump in and answer. So one is, when do you perform trochleoplasty? I think we kind of cleared a little bit the indications. Is anyone from the panel willing to kind of, provide a very good guideline?
So and I think every one of us, Petri and I, and Juan and I, Nick, you, probably all have slightly different indications. Again, for me, it's a flatter convex trochlea. And I know that other people need at least a spur height of 5 millimeters before they do it. So it is different from surgeon to surgeon, but those are my indications. I don't know if others want to say what theirs are.
Yeah, I would say it's really a J tracking, jumping J sign, whatever you want to call it. To me, it's a severe abnormal tracking of the patella, and it's quite often the case that the trochlea is flat or convex. So basically, that's about it.
Yeah.
I
When you-
agree. Go ahead.
Yeah, so I think in clinic, when you see the J sign, the classical, as Lee told, that it's because of the convexity of the patella jump, trochlea, the patella jumps. So if you see that, I think those are the cases where you can think about trochleoplasty as a primary option.
Yeah, I agree. I think, some people would reserve that for only revision cases, but I think you kind of pose yourself to get a revision, need, because you're not doing and you're not addressing the problem. So I don't think that is a problem on the indications is based on trochlear dysplasia.
And if you
Next
look at this-
question. Yeah.
And Nick, if you look at the studies real quick, if you look at the studies, and it's the same as anything else, the revisions always do worse than the primaries. So identify that patient and do it as a primary procedure, and they do better. Sorry, go ahead. I just wanted to throw that in.
Briefly explain the crossing sign in the de jure classification. I think we went through that in some presentations. That was very early on. Any tricks to identify that, or anything that, somebody does that is like, hey, straight.
Crossing sign identification is it's just got to be a perfect lateral. If it's not, you can't see it.
Yeah.
I find the de jure classification an elegant interpretation of the lateral X-ray, of the subtleties of a lateral X-ray, but I don't really use it to indicate anybody for any specific type of treatment. It supports my MRI, basically.
And relevant question for this is what are the current radiological parameters for trochlea and patellofacet geometry and guidelines for correction? I think it has the discussion of the trochlear dysplasia. I don't think that, the patellofacet geometry is irrelevant. I think, like you have the trochlea dysplasia that sometimes affects the shape of the patella. Any tricks, any ideas on this, on any specific radiologic parameters that you use to guide your decision making?
With regards to patella, we published I think back in 2020, we published, I think, what is still the largest series in the literature regarding patellar morphology. And, it was highly variable amongst the control population and patients with dysplasia. You do see those unicorns that have like a concave patella, right? And you can actually fix that. Dave DeJour has shared a technique with me with a closing wedge patellar osteotomy. It's actually not that hard to do. And I've done that, I think, 3 times now. But back to general patellar morphology, what we found in our study was that the facet angles of the lateral facet of the patella were amazingly consistent. The medial side was what changed the most. The lateral facet always hovered around 20 degrees, right? And a normal LTI is roughly 20 degrees. So I think aiming for that sort of geometry when you're doing a trochleoplasty is going to benefit most people. I do think as we advance our technology with this patient-specific instrumentation technology that we have now, we could probably start designing trochleoplasties to fit, as perfect as possible patients' unique patellas. But I do think that from a broad perspective, that shooting for that LTI of 20, and again, I don't know about, and that probably correlates to depth of around 6 millimeters for a male and 4 millimeters for a female and all those different things. But I think that those are somewhat irrelevant or less important measures. I think that LTI 20 degrees, that matches your lateral patellar facet quite nicely, I think, in most people.
Yeah, I agree. I agree. It's basically I would say that the patella osteotomy could be sometimes indicated, but it's really rare. And it's in extension, the patella tracks on the lateral facet. So basically you can cope with that even though the medial contour of the patella shapes would be abnormal.
Yeah, perfect. We have a lot of these coming, so I'm gonna go a little bit faster in respect of everybody's time, depending on the time zone as well. Superficial flat, good option for MPFL without screw fixation, like QTFL. I agree, like you avoiding the screws and everything. Why avulsion fracture more often happen at the lower medial edge of the patella when the patella is dislocated? I think it's a matter of biomechanics, and anyone has any ideas? The way that the MPFL axis is bringing the kneecap, down. So I think when it dislocates, is the lower part of the patella that essentially receives most of the stress. Any ideas on that? Any different thoughts?
I can't say I've thought about it. It's an interesting concept.
Favorite score for evaluating risk for dislocations? Let's go around the panel. Rajiv, what do you use? BUMF, patella instability severity score.
I think we use the patellofemoral instability score, and normally. Yeah.
Petri,
The Banff, yeah.
Sina.
Yeah, I like Banff. I do, and I went through the score with Laurie a fair few times, but I do not think it covers the entire cohort of dislocated. So I think you really have to assess each one on their merits. I don't think there are any scores at the moment that really address all the factors that we need to include.
Juan Pablo.
Yeah, I use Banff, I use Norwich score too, but I try to evaluate every patient individually and see each risk factor to decide. Yeah.
Lee.
I don't use a specific severity score right now. I usually indicate them off of recurrent instability episodes, and their quality of life being affected by it. A first-time dislocator with an osteochondral fracture, I'll also operate on those, but I don't typically do it. I haven't applied a specific score to them on a routine basis.
Sandeep.
I think it's the recurrent instability. RIP is the one I feel that's a good indicator.
I think as long as you have in mind that there is a risk and you're evaluating certain things in order your decision making, that's the idea. I think that's rational. I think all scores have, their pros and cons. And I think, like there is overlap. So I use the patellar instability score, but I modified so that hyperlaxity because it wasn't
Yes.
out on that. If you do habitual dislocations, what kind of surgery would you advise? Thanks, this is for you.
Well, I firstly don't like the term habitual, but I think that if you've got a patella that is dislocating with every flexion extension cycle, then I assess them exactly the same way I do every other patella, to be honest. I don't have a different way of assessing them. The question about dislocated inflection, though, I think that's important to note because if you have a dislocated inflection, that is a very different anatomical animal. And so you really do need to assess the length of the quadriceps mechanism because the majority of those are tight. And so you may need to perform quads lengthening of some sort in order to get the patella back, as long with a long lateral release, as you do in many of the congenital dislocators.
Yeah, I think Nick,
Petri.
I think it's
Go ahead.
I think it's a lateral release and medial plication. This combination we have been using for ages, and they are different techniques. And that is the best way to stabilize the habitual dislocation, either inflection or extension. So, Sena, one question for you. So, how often you see that such patients with habitual dislocation? Because most of these patients we treat when they are skeletally immature. So, when do you plan for bony procedure in these patients?
So let's just define exactly what we mean by habitual dislocation, really, because the definition is variable as well. So what are we referring to?
So I think habitual dislocation now normally we describe when the patella dislocates with the movement, either with the flexion or with the extension. So suppose it's dislocating in flexion.
Yeah. So like I said before, the patients who are dislocating in flexion, they could be patients who have congenital instability, and they could be patients that have tight quads mechanism from some other cause. So again, my assessment is based upon an assessment of the biomechanics of the PFJ. So based on the extrinsic alignment of the limb and the torsion, but mainly I would agree in these cases, it's a soft tissue problem. And so you're trying to manage the soft tissues in the context of the underlying pathoanatomy. And the majority of them have very tight lateral structures, and they will need a long lateral release. And if you can't get them back with that, then you do have to look at lengthening the quads mechanism, which I like to do with a coronal lengthening or a VY-plasty. Petri may also have an answer to that.
Perfect. Juan Pablo, anything to add?
Yeah. No, I think that when it's inflection, you always need to do big lateral releases and lengthening usually I do for the extensor mechanism, the quad tendon or something. And in extension cases is those cases that have this big J sign that are like dislocating every time they do full extension. So you have to think about trochlear dysplasia. You have to think about patella alta. That's what I think about.
Yeah, great
A
point.
lot of these people are going to have more than one pathologic abnormality. So, like, I just fixed one. She had a fixed dislocation, so she didn't dislocate every time she moved. It was just sitting out. So she had valgus and dysplasia that both needed to be corrected, right? So you've often got more than one abnormality, and that just needs to be evaluated for. Different for everybody.
And those ones you also want to make sure they don't have an underlying condition like a congenital femoral deficiency or a fibular hemimelia, because you can get subtle cases of those conditions that do present with fixed dislocated patellae.
Yes.
And there are some very rare cases that the trochlear dysplasia is also on the distal part of the trochlear lateral femoral condyle junction, and even that could be addressed in some cases if the shaft tissues are not enough.
I learned that from Petri. I've actually fixed a couple of those now. That was very helpful to kind of like elevate distally.
These are our great discussion. Questions keep coming, so I'm not sure how we'll go, but I think we have a group of questions about trochleoplasty, resection of subchondral bone, and viability of the cartilage, age limit for trochleoplasty, and when we have cartilage changes, arthritic patella facets, is there limitation of the trochleoplasty? I don't know who wants to get that.
I want Petri to talk about his MRI study.
Yeah, the cartilage, the last question, the cartilage condition is also, of course, a limit. If it's too worn out, you can't do any thin flap trochleoplasty anymore. Basically, in my hands, it ends up to be a combination of thick flap and thin flap trochleoplasty. You might cope with a thick flap trochleoplasty even with a little bit more worn out cartilage. But the cartilage viability has been shown to be amazingly good after the trochleoplasty, even with the chin flap technique. So we actually did presented our series of 30 MRIs 5 years post of thin flap trochleoplasty in the last ISAKOS meeting, and trying to get that out to be published pretty soon. So what we did found that every case of these 30 patients, minimum 5 years post-op trochleoplasty, they did not had any severe cartilage viability issues, and typically quite often it was the same ICRS thickness of the cartilage in different regions of the trochlea, so only very minor. And as we heard from Lee, that the natural history of trochlear dysplasia is typically early Patellofemoral OA, so it might be that we might be able to prevent some OA issues in these patients.
I agree, and in order to get the age limit, I'm always hesitating when they are like tenor score is low, but I think if you are an age of 13 and have 1 or 2 years of skeletal growth, I think it's safe to do a trochleoplasty, thanks to some of the data that you and Lee have published. Any thoughts from anyone in the panel for the age group, age limit, trochleoplasties?
As long as they're pubescent. I think if they're prepubescent, you risk a growth disturbance. I've got one. And then on the upper end, it's just a question of cartilage health. My oldest is 45.
Yeah, exactly. Manage patellar instability inflection. I think we touched this typically. Apprehension tests for clinical evaluation. This is very, important. And patellar instability inflection, essentially, you need to see what other contributors are there. So I think that's what, the rationale is this. femoral fixation in sling technique, the Moonlau, is it too much non-anatomic? What do you think?
I don't think so.
You know,
I don't think so. There's always some benefit of not being too constrained. You know, if it's quite near to anatomical, I think it works.
As long as you follow the principles of isometry and you test your graph and you see and you don't make it too tight, I don't think there is a very, very rigid, rule. But see what works on your hands and what are the things that you need to change in order to address the potential, risk for a non-anatomic technique. And then there's the MPFL reconstruction affects coronal alignment in time in children. Do you need to worry?
I think we have to be cognizant of that. I've thankfully, the appropriate fixation point is always going to be distal to the physis. And I think that, there's several different ways to safely do an MPFL reconstruction in a kid. And the reports of growth disturbance are, little to none. Like, it's very different from an ACL in that regard. But I think that we always have to be vigilant. If we're not, then that's when I think we could probably cause a problem.
Perfect. I want to
Yes.
thank everyone. Any last minute comments? I think we are well overdue time, but I'm happily seeing the participant list and nobody wants to leave, and I hate to finish it up. Any last minute comments from anyone?
I think it was an excellent webinar. We can have vote of thanks by our past secretary, Dr. Sandeep Biraris. Yes.
There's never enough time, but I'm sure that everybody will be in the ISAKOS and come and pin us down.
Looking
We love
forward
these
to see
things.
you all.
You can see
Yes.
it. So in
Thank you.
Monaco, when you see us, pin us down. Thank you all for the amazing presentations, for the quality, for being on time.
Sandeep.
This was great.
Thank you. Thank you very much. On behalf of Indian Arthroscopy Society, I would like to thank our chair and the faculty, Dr. Nicholas, and apologies for Dr. Adnan, who couldn't join, and all other faculties, Dr. Petri, Dr. Sundar, Dr. Shiana, Dr. Martinez, and Dr. Lee, for their wonderful presentations. And from the ISAKOS office, I would like to personally thank Sue, Laura, and Alexa for making this possible. And on behalf of Indian Arthroscopy Society, many more thanks to Dr. Arumugam, President, Indian Arthroscopy Society, past President, Dr. Sachin Tapasvi, and our dynamic Secretary, Dr. Rajiv Raman, and the whole Executive Council. And I would like to invite all the speakers, do register for ISAKOS Congress, which is now scheduled from 8th to 11th of June in Munich. So see you all there. Thank you very much. I think we can end it here. Thank you.
See you.
Thank you.
Thank you, everyone.